Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is the November 11th, 2025 issue. This week's issue moves from valve intervention to developmental genomics, from coronary CT imaging to accelerated triage in the emergency department. Each paper examines how precision, context, and physiology shape patient outcomes. Pretty excited about this issue, happy to move into it, and hope you enjoy it. Okay, let's get started with the editor's page. I took on an issue that's been bothering me for a while, this issue about the way that risk models are kind of one size fits all. I titled it The Geography Gap, Risk Models and the Problem of Place. So imagine two patients, say both 55, identical risk factors. One lives in Mississippi and one in Massachusetts. You use the score, their predicted 10-year risk may be the same, but their actual risk is different by a lot. That's a problem of calibration. The issue is that people in Mississippi have, like a 50% higher risk of cardiovascular disease than the people in Massachusetts. There is geographic variation in the risk of disease and of death as a result of cardiovascular disease. So how can you use the same risk calculator and get the same estimates regardless of where people live? That didn't make sense to me. The issue is that people may say that they validated these across different data sets, but in each case, they're bringing together data from various different geographies and kind of producing an average. And on average, these scores can work. They can work in US or in different countries or in different regions. But the truth is that if you actually get to more granular geographic layers, so you either look at, for example, different states or within cities, you can look at places that have vastly different cardiovascular risk and outcomes, there needs to be some correction factor. And that's what I take on in this editor's page. I write that the future of risk prediction is bright. Multimodal inputs such as genomics, imaging, wearables, environmental exposures, all this will create richer, more dynamic models. But even the most sophisticated algorithm cannot escape context. The real frontier is not just building better models, it's learning to deploy them wisely, recalibrate them honestly, and use them to illuminate and eliminate the disparities we have accepted for too long. I go on to say, one size does not fit all. The map is not the territory. Until we stop navigating with maps drawn from other places or some average place that does not exist, every prediction we make carries an invisible asterisk. Your results may vary. It's time we made that asterisk visible. Okay, let's get on to the research. The first paper in this issue, using transmitral pressure gradients in residual mitral regurgitation to optimize outcome after transcatheter edge-to-edge repair, by Tsunemoto, Hayashida, and colleagues from Japan, the Ocean Mitral investigators. This group aimed to evaluate the clinical significance of mitral regurgitation reduction and transmitral mean pressure gradient elevation in patients with functional mitral regurgitation after M-TEER. The reduction of mitral regurgitation after M-TEER and its association with improved prognosis in functional mitral regurgitation has been well established in many previous studies. Of course, M-TEER may potentially lead to a risk of mitral stenosis, and studies have shown that in patients with degenerative MR, elevated transmitral pressure gradient, in addition to residual MR, is strongly associated with adverse prognosis. They note that in the paper. And so this combination of MR reduction without an increase in the transmitral pressure gradient has been considered ideal, but it hasn't been clear in functional MR how all of these relate and what might be the best combination. This group used a large-scale multi-center data from Japan to examine the impact of residual mitral regurgitation and transmitral pressure gradient after M-TEER on clinical outcomes in patients with functional MR. In slightly more than 2,300 patients with functional MR, each 1 millimeter of mercury increase in post-procedural transmitral mean pressure gradient was associated with a 10% higher risk of death or heart failure hospitalization. The lowest events occurred in those where the MR was less than or equal to mild and the transmitral pressure gradient was less than 5 millimeters of mercury. And the post-procedural transmitral pressure gradient was associated with worse long-term outcomes, and this was confirmed by several analytic approaches. They conclude by saying that considering both MR reduction and the transmitral pressure gradient management as a sort of dual target could serve as a useful marker for risk stratification. Of course, this is an observational study and has all the limitations associated with that, but the findings make sense. The editorialists, Chakravarti, Makar, Scaff, and Makar, write that the main message from this study is clear. Mitral valve gradients are as important as MR reduction after M-tier in the functional mitral regurgitation patient population. The editorials contrast this with findings from the COAP trial, but they make the point that this study, the largest so far, represents real-world experience treating a diverse range of mitral valve anatomies. They end their editorial by saying whether functional MR patients unable to achieve the dual targets of MR reduction and low transmitral gradients with M-tier may be better served with transcatheter mitral valve replacement remains an open question. The next study, placental malperfusion, is associated with adverse outcomes in congenital heart disease and with genetic variants in placental developmental pathways. I have to say I learned a lot in the course of evaluating and now publishing this study. It's not an area that I had focused on before. So this placental malperfusion is a vascular disorder. It's impaired maternal or fetal placental perfusion and is common in fetuses with congenital heart disease. But the impact on outcomes and the mechanisms, all this is still a bit unclear. This study sought to determine whether fetuses with congenital heart disease with placental malperfusion had adverse outcomes and genomic variation in vascular or placental developmental pathways. This placental malperfusion, by the way, is associated with adverse outcomes in the previous literature in the general population, such as intrauterine growth restriction, preterm birth, stillbirth, poor neurodevelopmental outcomes, and so forth. This group previously demonstrated that this placental malperfusion is associated with impaired fetal growth in congenital heart disease. And they were very interested in whether or not there were shared pathways between the abnormalities of the fetal heart and placenta and potential dysregulation of these shared pathways. They studied 299 fetuses with congenital heart disease with and without placental malperfusion. And they had maternal, genomic, placental, and outcomes data. The placental malperfusion was present in about half of the fetuses. What they found was that the placental malperfusion was associated with impaired fetal growth, longer hospitalization, and possibly increased mortality in congenital heart disease. And then sort of to extend this mechanistically, they found that fetuses with congenital heart disease and the placental malperfusion often had the deleterious de novo variants in several key placental and cardiac developmental pathways. This is a very sophisticated analysis and it's pretty far afield from maybe frontline adult clinical cardiologists, but it's really interesting the way they're trying to unlock the secrets here. And, they had a figure that looked at functional protein interactome for genes and de novo variants, where how all these things relate. What they're trying to do is identify signaling pathway dysregulation underlying this placental malperfusion in congenital heart disease and identify those as potential targets for future intervention. Look, JACC wants to be able to publish stuff like this. It really is the next frontier. And we are also very interested in congenital heart disease. We're interested in the entire breadth of cardiology. We have a great editorial that kind of puts this in perspective, Two Sides of One Circulation by Ronay and Wilkins-Hogg. They're writing that placental malperfusion, once viewed as a coincidental finding in congenital heart disease pregnancies, is gaining recognition as a potential driver of the higher rates of maternal comorbidity, fetal compromise, and impaired long-term outcomes. They highlight that what distinguishes this work is the explicit focus on placental disease, reframing the placenta not as a passive bystander, but as an organ whose genetic and molecular integrity is central to fetal cardiac outcomes. And they highlight that this work is going to lead to biomarker discovery, therapeutic targets, and risk stratification. And that this study, they say, quote, pushes the field toward a unified model of congenital heart disease and placental malperfusion as disorders of shared developmental genetics. And the future research integrating maternal health, placental biology, and fetal genomics are going to be essential to advance risk prediction and open avenues for novel interventions. The next paper is Computed Tomography Angiography, or Standard Care After Left Main PCI by D'Ascenzo, Campo, and colleagues. It starts with a context that the clinical benefit of routine coronary computed tomography angiography after PCI for unprotected left main disease is uncertain, And the objectives of this paper was to evaluate whether CCTA-guided follow-up improves clinical outcomes versus a symptoms or ischemia-driven care approach after left main PCI. This is a randomized trial. It's called PULSE. It's a prospective multicenter open-label trial. Total of 606 patients treated with a second-generation drug-eluting stent, enrolled from October 2019 to September 2024, randomized 1-to-1 to CCTA at 6 months or standard care. Primary endpoint was a composite of all-cause death, spontaneous MI, unstable angina, or definite or probable stent thrombosis by 18 months. They justified the study by saying that recent years has shown that CCTA has been used increasingly as a tool for diagnosing and monitoring de novo and established CAD, including patients with previously implanted stents. The primary endpoint occurred in 11.9% of the intervention arm, the one that was being monitored by the CCTA, in 12.5%. So 11.9 versus 12.5%, hazard ratio is 0.97, non-significant difference. The CCTA arm showed a reduced risk of spontaneous MI and an increased risk of imaging-triggered target lesion revascularization. Clinically driven target lesion revascularization rates were similar. They concluded that routine CCTA after left main PCI did not reduce the composite primary endpoint. The editorial by Collette, Bousset, Ikeda, Mizukami puts this in perspective. They took the approach of saying that the trial delivers a nuanced message. So they didn't just come out and say this was a negative trial. They focused on the fact that the routine CCTA, while not improving the composite outcome, appears to have prevented spontaneous infarctions at the expense of more interventions, prompted by the imaging findings. They essentially asked for more studies and suggest that if it's confirmed that it can reduce these spontaneous MIs, that it could still be important. They highlight that this represents the first randomized controlled trial focused exclusively on follow-up after left main PCI. They commend the authors because the adherence to the imaging protocol was excellent, nearly 90% of patients undergoing the imaging test, and that it reflected contemporary PCI practice with widespread use of radial access, second-generation drug-eluting stents, and intravascular imaging in 70% of the cases. They come down in the end by saying that routine CCTA may not be justified and that selective surveillance may be appropriate, especially in patients with high anatomic complexity, two-stent bifurcation PCI, incomplete imaging assessment during the procedure, or persistent uncertainty about procedural optimization. Certainly, there's room for more studies here. The next study is safety of using risk stratification along with high-sensitivity cardiac troponin in the emergency department, a secondary analysis by Lee, Mills, and colleagues, the historic trial investigators. The context for this is that implementation of an early rule-out pathway for MI using high-sensitivity cardiac troponin to risk stratify patients reduces length of stay in hospital admission. And the question is whether gains are similar in low and intermediate risk patients. So accordingly, the objective here was to evaluate the effectiveness and safety of risk stratification with high-sensitivity cardiac troponin in patients with suspected acute coronary syndrome stratified as low and intermediate risk. This was a secondary analysis of a stepped wedge cluster randomized controlled trial. In the primary publication of the historic trial, they showed that the implementation of high-sensitivity cardiac troponin to risk stratified patients with an early rule-out pathway reduced this length of stay by 3 hours and increased discharge from the emergency department by 21%. But the event rate for the safety outcome at 30 days was low and non-inferiority was not demonstrated. So they're posing this thing about whether implementation reduces length of stay and increases discharge in both low and intermediate risk patients is unknown, and that's what this is primed to answer. This was a pre-specified secondary analysis of the historic trial. The study was conducted in 7 acute care hospitals in Scotland. The hospital site was the unit of randomization. The trial enrolled just over 31,000 consecutive patients, average age of 59 years, 45% were women with suspected acute coronary syndrome. Of those, about half were classified as low risk and about half as intermediate risk. In the end, this risk stratification with the high-sensitivity cardiac troponin reduced length of stay and increased discharge from the emergency department in both low and intermediate risk patients with suspected acute coronary syndromes. In the low risk, 83% were discharged from the emergency department versus 62% with standard care. In the intermediate risk, 55% in the risk stratification group were discharged from the emergency department versus 36%. So these are pretty substantial differences. The proportion with myocardial infarction or cardiac death at 1 year after discharge was actually lower in the risk stratification group in both the low and intermediate risk groups. In the editorial, Jaffe and Sandoval, who titled their editorial, "Will Historic Be Historic?" they make the note that historic report, the original report, failed to meet its safety endpoint. And they argued it because of the way that the inferiority margin was calculated. And they say that they've argued previously that the event rate was sufficiently low that the results should be considered valid. They emphasize that the present secondary analysis, this one we're talking about now, really emphasize this issue of safety further. They make the point that the bottom line of this study is not as much that the rule-out protocols for MI perform well and are safe, but that when a patient has a troponin level that is very low or within normal range, serially over time, that patient has an excellent short-term prognosis. They go on at the end to say we're entering a new era and changes in biomarker and biomarker assays are going to continue at a rapid pace, and it should encourage the field toward objective randomized trials, but also, they say, remind us to be cognizant of what those trials give us and what questions in the long run they cannot answer. In this issue, we also have a great heartbeat section from Eli Fredman, What We Give, Reflections from the Heart of Pediatric Cardiology. I highly recommend it to you. He talks about the struggle between work life and home life and says, to those of you just starting this journey, you do not have to know everything. You only have to be relentlessly curious and humble enough to ask for help. Let the weight of the work soften you, not harden you. Keep a collection of your own wins, a thank you note, a case that clicked, or a smile from a patient who remembered your name. As usual, we have an Amara Yad image. This week, the variable relationship of the coronary sinus and the mitral annulus. We have some letters and replies. In this issue, we also have reprinted content from other JACC journals, and we have something from JACC Asia, Nationwide Epidemiology and Management Time Trends for Atrial Fibrillation, insights from the Korean AF fact sheet, a brief report, non-O blood groups and cardiovascular outcomes in COVID-19, findings from a large multi-center study, from Hannah Leva, Greg Piazza and colleagues. This was something that was brought up repetitively during the pandemic. And what they find is an association between non-O blood groups and excess risk of cardiovascular outcomes in patients with COVID-19 compared with O blood groups, and that this was consistent in multivariable analysis. This is just an observation, again, brief report, and they argued for continued research to explore the mechanisms linking blood group antigens and cardiovascular complications. And finally, we have a gem of a piece, an editor's page from Matthias Nahrendorf's first issue as the new editor-in-chief of JACC Basic to Translational Science, Unleashing the Power of the Beehive to begin a new era for JACC Basic to Translational Science. He's terrific, amazing, building on the successes of Doug Mann before him. Stay tuned to this journal. It's going to impress you. He writes, some of you may know I enjoy work most when looking at making sense of new data with fellows and colleagues, chasing the precious click when seemingly incongruous facts fall into place and discovery emerges. Although I intend to keep pursuing that click, I will now dedicate some of my time to smoothing your path to publishing such discoveries. He ends by saying, let us not accept this current status quo. Let us unleash the scientist's beehive brain to make publishing what we wish it was. And finally, we have a couple cool case reports. I'm going to note one of them in particular, ice water drowning survival after 147 minutes submersion in 7-degree hypothermic circulatory arrest. This one is amazing. And finally, tumor necrosis factor receptor-associated periodic syndrome. Altogether, it's a great issue. I hope you enjoyed it. I hope you enjoy this podcast. As I usually end, thank you for listening. Stay curious.